Hello, everyone. My name is Jeff Hsu, representing the Circulation COVID team. I'm an advanced heart failure and transplant cardiology fellow at Ronald Reagan UCLA Medical Center and the West LA VA Medical Center in Los Angeles, California. Today, it's my privilege to be joined by a cardiologist on the front lines, Dr. Neal Dickert, Associate Professor in the Department of Medicine at the Emory University School of Medicine and in the Department of Epidemiology in the Rollins School of Public Health in Atlanta, Georgia, one of our country's hotspots in this pandemic. Dr. Dickert, thank you so much for joining us today and for sharing your expertise with us as part of the Circulation Updates from the Front Lines initiative.
Thanks so much. I'm happy to be here.
There have been so many challenges for our cardiology community in dealing with this pandemic. And one of the challenges we want to focus on today are the ethical aspects that have arisen during this early phase. As our country and hospital systems prepared for this pandemic months ago, we heard about experiences in countries like China and Italy, and we were faced with the very real possibility that we may have a shortage of resources in our hospitals, including ventilators, ECMO circuits, even medical staff. Now, as we prepared for surges in our hospitals, we started to think a lot about justice issues and how we allocate these limited resources among our patients. Now, in your experience on the COVID front line in Atlanta, can you walk us through how you thought about these issues and also how you recommend presenting these issues to our patients and their families?
Yeah, these are really hard decisions that I think all of us have been thinking about having to make. Fortunately, for the most part, I think this really tough decisions about allocating critical care resources have not had to be made in the US for the most part, and that's a good thing. But all of us, my institution and I think most major medical institutions facing a significant illness in the context of this pandemic have had to think through how we would deal with a situation where we had to develop or implement crisis standards of care. I think you mentioned that there are justice issues, and I think a lot of this really does shift the way we normally think about allocating care from how do we take the best care of the patient in front of us to how do we take the best care of the most number of people, and how do we make those decisions fairly. So we, like other institutions, have been working to develop policies and systems that can do that fairly and in a way that's transparent. And there are important priorities that people have had to decide among, and they compete with each other. One of the primary allocation frameworks that have been that's been put out, and really the one that we're basing much of our thought on, prioritizes maximizing the number of people who can survive to discharge, and prioritizing people who have a good chance of having a number of years after discharge if they get through the acute illness. But these issues are complicated. They're not isolated to just dealing with patients with COVID, right? Because we have cardiology patients and other kinds of patients with severe illness who are going to be, in some sense, competing for the same sets of resources. And so we have to have ways to work through that. None of these decisions are easy, and nobody wants to make them. But I think this process of having to work through it and trying to do it in advance has been important and productive, and we're still working through that, just like a lot of institutions are. You raise an important question about how you talk to patients and families about this. And I think this is, as someone who takes care of patients like you and others, it's gut-wrenching to think about the idea of having to talk with patients and families about not being able to provide care that we would normally provide for them. Fortunately, as I say, we have not hit a situation where those are the kinds of conversations that we're having to have. For the most part, certainly not in Atlanta, we haven't hit that. But I think it is important to have those conversations and to be prepared to tell people what kinds of decisions we're making. They deserve to hear that. And I think it's important that our processes be transparent.
Absolutely. And another really complex challenge in managing our critically ill patients with COVID-19 has revolved around CPR by our medical teams, and with issues such as needing to protect our team members from exposure to the virus, to the utility of CPR in this patient population. Can you tell us and walk us through how you're thinking about this problem?
This is something that I've thought a bit about, both from a research perspective as well as thinking about how we would approach it at our own institution. And this is something that the AHA has taken some lead on by issuing guidance on. Obviously, CPR is there's a couple of challenging issues. One is that the process of resuscitation, particularly chest compressions and intubation, have high risks of aerosolization, and so are in that sense interactions with patients that are higher risk for people who are in the room. The second, obviously, is that there are always questions, especially in hospital, in hospital and out hospital rest, about the fact that the likelihood of success will vary. There have been some discussion around whether the resuscitation outcomes in the context of COVID-19 are they similar to or different from other kinds of conditions? And the truth is, we all, this is all a moving target, and the knowledge of outcomes in COVID-19 is approximately 2 months old at this point, and changing by the day. And I think importantly, the AHA position, and I would say, certainly my position too, we have an obligation to provide care to patients in this context. And so we certainly don't have any kind of evidence that would justify making exclusionary decisions based upon a patient's COVID-19 status. So we take the position that it's important that we have an obligation to provide CPR. That said, we have an obligation to do that in a way that's safe. And so there will be differences in the context of this pandemic in terms of how this gets operationalized. And it's important for institutions to have a clear policy for that. Some of the key elements are things like people shouldn't have to go into rooms without PPE, right? So if it means that there's a bit of a delay because people are putting on appropriate PPE, that's part of what we have to accept to keep our workforce safe. All of us deserve that kind of protection, I think. It is also the case that there may be situations, I think, where it's tough. There are situations, I do think, where some components of CPR may get delayed beyond that. So if you're in a room and nobody's experienced with airways, your protocol may differ, and you may wait for someone who's experienced to come in and has appropriate PPE and has the requisite experience to quickly establish an airway. And every institution needs to think through how they approach that. Obviously, there are ways to try to minimize exposure by having only necessary people in the room and other things. Those are really important. The toughest issues are there situations where we think the likelihood of a good outcome is so bad that it doesn't justify exposing people to the risk of a resuscitative effort. I do think there may be those situations if we have patients who are clearly declining so precipitously that we reach a point of medical ineffectiveness. We all know those kinds of decisions as sort of classic futility decisions. Normally, we provide CPR in those circumstances if it's what patients or families want. The fact that we do have a potential or real risk to providers can change those equations in, I think, a very severe circumstance. Those will be by far the minority of cases. I think it's important to recognize we have an obligation to provide high quality care to all of our patients. There are some limited exceptions where I think in the context of COVID-19, there are some changes to how we do things, but for the most part, the big picture isn't radically different. But it's important for institutions to develop approaches that people know how to execute, so that we're not in a position where co-teams are at a bedside and unsure what to do.
Yeah, it's a very difficult challenge and a fine balance we have to achieve. And another question I have is, well, most cities have already seen the first wave of cases in our hospitals. Many worry tremendously about the second wave and future waves that can put us back into crisis situations. What policies should institutions implement in preparing to face these crisis situations? And as cardiologists, what are our responsibilities in this process?
In a sense, I would answer this similar to the first question, which is that if there's anything that's really helpful about what's happening now, I think institutions are getting on top of this and coming up with policies that if we get to, and all of us hope we don't, if we get to situations where crisis standards of care really have to be implemented, it's helpful that we've gone through this. It's been interesting. Everyone has been building on work that was done in the wake of the H1N1 threat. There were some seeds and some really important efforts in that, and that gave us a place to start. I think the approaches that have been developed over the last month or two will put us in a much better position to deal with future waves of this. I think with regard to cardiologists' responsibilities specifically, one of the things that's really important is to make sure that patients of different types and different kinds of illnesses are treated appropriately and fairly. To give you a very concrete example, one of the common ways to sort of score or prioritize patients is using things like the SOFA score. Well, there's a lot of cardiology patients for whom that is a bad predictor of inpatient mortality. Either it would overpredict or underpredict their risk. And we as cardiologists have an important role in offering our specialty expertise to make sure that our patients are appropriately treated and neither inappropriately prioritized nor inappropriately disadvantaged. But all of these are really gut-wrenching kinds of decisions that we have to make, and I think we, like other specialists, have an important role to play. The other thing I didn't mention in response to the first question that I do think is important is the importance of fairness and transparency. I think is really hard to overstate, especially in the context where we know we have background inequalities and disparities in predisposing illnesses and other things that make many populations especially vulnerable. So there's a real priority in being fair and equitable in what we do with all of this.
Yes, and these disparities we're learning more and more about every day. It appears more and more headlines in our major newspapers. Yeah. Well, thank you, Dr. Dickert. That's all the time that we have for this segment of our Circulation COVID Updates from the Frontline series. I'd like to once again thank our frontline expert today, Dr. Neal Dickert from Emory University in Atlanta. Thank you, Dr. Dickert, for your tremendous efforts, and we hope you and everyone watching this stay safe, strong, and healthy.
Thanks so much. I appreciate it.